Hello and welcome to Stalking Horse LLC's webinar for Modifier 25. I'm going to be your host, Stacy Sisto. And again, thank you for joining. We decided to put together this webinar for Modifier 25 because it seems to be a pretty popular topic for providers year after year. It also ends up on the OIG's hit list for auditing. Many years in a row, and sometimes it tends to skip a year, but it's always coming back. So it always rears its head again. So we're going to go ahead and get started. And so a couple of things to talk about would be the definition. So we're going to go over the technical definition of the modifier and who uses it, when you should use it, some examples of proper use and an example of improper use, and then some recommendations from us here at Stalking Horse. So let's talk about that definition. It's actually a pretty lengthy definition. So when you look at any of the technical definitions for modifiers, they're pretty lengthy, honestly, and sometimes it makes it a little bit confusing to try to figure out like when to actually apply it. So what we like to do is really break it down. So first thing to know is that to use modifier 25, the documentation has to be significant and it has to be separately identifiable. And then the service has to have been provided by the same physician or other qualified healthcare professional. We'll talk a little bit more about that as well. And it has to be on the same day of a procedure or other service. So to kind of put everything together, modifier 25 is used when you perform an office visit service or an evaluation and management service. So it could even be something, technically be something that's outside of the office, but it's office or other outpatient evaluation and management service. So something like your 99202 through 99215 codes, so your E&M codes. So when you perform that evaluation and management service, and then you also perform another service or procedure during that encounter or on the same day. So a great example would be if a patient comes in, they have a visit with the provider, and then let's say they also end up needing a flu shot. So they had a procedure on the same day as an evaluation and management service, but in order to get paid for both, you would append modifier 25 on the evaluation and management service. So for example, it would show as like, let's say 99213 was used for the E&M, and then that would have a modifier 25 attached to it. And then you would also attach your codes for the injection or the flu shot, let's say. And those would go out without that modifier. So the 25 goes on the evaluation and management service. But in order to be paid for both services, again, they want the evaluation and management service to be something that is significant, something that is separately identifiable, so something that's clearly separate from the procedure or other service that was performed. And it would be by the same physician or other qualified healthcare professional. And again, that's going to rear its head here and again in a few more minutes. So we'll talk about what that means. And again, on the same day of a procedure or service. So if they come in one day and have an office visit, and then the next day they come in and have some kind of procedure, this does not apply. It would be on the same day. So you may wonder, well, who uses it? And honestly, most providers do to some degree. They're going to use it. So it's very common, but it is sometimes overused. So sometimes this modifier is attached when it's not needed, which then can actually make it look like you're overutilizing that modifier and could actually put you as an outlier where you may be selected for an audit for modifier 25. So if your practice is identified as reporting this modifier more times than the average, you could be selected for review just based on the fact that you're using it more than the average office. Not necessarily that you're using it wrong, but they would come in and do an audit just to find out. So I told you that we'd talk more about that same physician or other qualified healthcare professional. So you can actually find a lot of information on Modifier 25 and proper use through your Medicare Administrative Contractor or your MAC. So one of the Medicare Administrative Contractors is Novitas Solutions, and they have a fact sheet. And that fact sheet I found to be very helpful just through the years. Novitas is one that has some really good information out there, typically for education. And so they define the same physician or other qualified healthcare professional as physicians of the same specialty in the same group practice. They are considered the same physician. Therefore, they must bill and be paid as though they were a single physician. So this is all to say, if you're in the same group practice, if you're a provider within the same group practice, and you perform a service on the same day as another provider performs, let's say, an evaluation management service, that modifier 25 would need to be appended to that evaluation and management service code. And this actually happens more often than what you would think, because we have mid-level providers often in practices with specialty providers, as well as some larger groups. So a patient could come into one provider for an annual wellness visit, let's say, and then they may see another provider and receive some kind of procedure or injection on the same day. It does actually happen, but remember that the mid-level providers, so nurse practitioners, physician's assistants, are included in that definition. And it's also important to remember that they are credentialed as general practitioners, so non-specialists. That can cause issue when you have a larger group practice that's multi-specialty, because sometimes you may have a primary care office, and then let's say a cardiology practice that's like together under the same name, right? Group name, but they're different specialties. And sometimes there may be a nurse practitioner that works with the cardiologist, but yet because they are credentialed the same as a primary care, if primary care and the nurse practitioner see the patient on the same day, that can sometimes cause claim issues. So just sort of being aware of that is important. And again, sometimes there could be an annual wellness visit as well as an E&M and even an injection on the same day, because it's very common during wellness visits for patients to be like, oh, I do need my flu shot, or I'm due for my pneumonia vaccine, or what have you. So it's just important to know that that same group is important and what visits the patient has actually had in one day. So it can actually be pretty challenging for the staff to bill appropriately. They have to really pay attention to everything that's going on for that patient within that group practice on the same day. So pretty interesting. It goes a little bit deeper than what one would think on the surface. It can get a little bit complicated. So now that we know that, we may want to talk about when to actually use it. So combination of things that we need to talk about. So a minor surgical procedure is performed with a global period of 0 to 10 days. So we're going to revisit that global period concept, as well as talking about the 0 to 10 days, what significance that has. And then again, remember that the office visit, that E&M visit, has to be separately identifiable, has to be a separately identifiable service that occurs. And the documentation has to really support that modifier 25 usage. So again, the only way we can really prove something is through the documentation. It's kind of like that age-old analogy, or what they say, like if it wasn't documented, it wasn't done. So if you are saying that a service was significant and separately identifiable, it really needs to be demonstrated through the documentation. So let's talk about some tips here. New patient codes, interestingly, so 99202 through 99205, do not normally require modifier 25 to be appended to it in order for those new patient codes to be reimbursed separately. Normally, they are automatically excluded from global surgery requirements. So this is important in particular for some specialty providers, like dermatology is a good example, as well as like orthopedics. So sometimes in those specialties, well, more often in those specialties, I should say, a patient may come in and they may actually require something to be done on that day of their new patient appointment. So suppose I am a patient that's coming in to an orthopedic practice and I have this just killer knee pain. And I come in, I have a new patient appointment. I have some x-rays with me of my knee, and the orthopedic doctor says, you're a new patient here, but I can see here, hey, you've got some really bad arthritis in there. I know you're in a lot of pain. We can go ahead and give you an injection today for some relief and give you an injection into your knee. But we also need to talk about, some what options are available to you, possibility of surgery, what everything looks like. So I may have that new patient appointment. And of course, that would be important to the provider as I'd never been seen there before. So even though they've given me this injection on that day and I'm a new patient, because I would be a new patient, normally that modifier 25 is not required to be reported for a new patient code. And many payers have gotten better about that because, again, we don't want to like overuse that modifier 25. So when you don't have to have it reported based on payer guidelines, I would recommend not reporting it again, so you don't kind of become one of those outliers and then put yourself kind of in the mix for a potential audit. Now, there is an exception, of course, as always. So there are some payers that will require that 25 modifier still to be on there for certain types of injections or infusions. So it is important, again, to kind of know your payer. And even from state to state, it varies. So I'll tell you that we work with some clients in different states, and our main office is located in Florida. I actually myself live in Florida, but there are practices within the state of Florida that we work with that do require the modifier 25 to be put on there, even for new patient appointments. Let's say I'm going to use the EKG as an example. So if the patient has an EKG and an office visit, many times we are having to put the 25 modifier on there, even though technically maybe we shouldn't be required to because it's not an injection or infusion type of situation, but they still require it. But in other states where we have other clients, those MACs and some of those other payers do not require it. So it is important, again, to know your payer specific guidelines. We'll touch on that again. So this is, again, like a normally that with a new patient visit, you don't normally need that modifier 25 because they know that that patient is just establishing with you as a new patient, but just pay attention to individual payer guidelines. We'll talk about that some more here in a minute. Also, as I mentioned, looking into your Medicare Administrative Contractor, your MAC, looking into their websites for additional information can be super helpful. So I mentioned before that I'm in Florida, so I actually pulled this information from First Coast Service Options, who's the Medicare Administrative Contractor for Florida, and they actually have a decision tree. So if you're unsure, hey, should I be reporting modifier 25 on this? They have a little decision tree. So first question that comes up is, was a procedure performed on the same day as the E&M? If the answer is no, then modifier 25 is not appropriate. If the answer is yes, then the question is, was the E&M significant and separately identifiable? So again, you have to make sure that your documentation shows that. If the answer is no, then modifier 25 is not appropriate. However, if the answer is yes, and you feel that it's appropriately documented that way, then you would bill the E&M code with the modifier 25. So there's always exceptions to rules. There's a little exception section, and they say inpatient dialysis service, so an E&M same day as dialysis, is denied unless It's unrelated to treatment of end-stage renal disease and was not or could not be furnished during dialysis. So something to consider there as well. Also, some notes. Generally, separate payment is not made for E&M services performed on the same day as a minor surgery or procedure. So let's talk about that for a second. So I used an example earlier of me being a new patient and needing an injection in my knee, right? So let's take that same scenario, but let's say that I'm an established patient this time. So this gets very tricky, especially in orthopedics, because if I'm an established patient and this condition is known and it's been discussed and I'm coming in for this injection, ordinarily an E&M and the injection would not be covered because the work that's pre-procedural or the work that's done in determining if I would need that injection is included in the payment for the injection. So they do not pay for a separate E&M with that type of procedure, especially if it's something that was scheduled prior. Another tip that First Coast gives is always consider whether you are treating at least 2 different diagnoses that require an E&M. Now, that's not a hard set rule. They just said always consider. So just so that you're aware, that doesn't mean that it is not possible for it to be the same diagnosis. So let's again stick with my example of the knee pain or knee arthritis. If I come in and I'm an established patient and the doctor says, oh, you really would benefit here from an injection today. However, this knee is worsened so much, and we really need to talk about a knee replacement. And the work that is put in is significant and separately identifiable within the documentation that this provider has spoken to me about having surgery, and a decision has been either made or that discussion was documented, there is possibility there that then there would be support for a significant and separately identifiable E&M. But again, don't, abuse that. Make sure, that that's occurring on that day. I know a lot of times with EMRs, some stuff can get carried over. So we want to just make sure that this isn't copy and paste. This is all unique to that visit at that time. And so again, it's not a requirement that there be a separate diagnosis, but the work has to be, again, significant and then also separately identifiable within that documentation. So I mentioned before that we would talk about global surgery a little bit. So we had said that for the 25 modifier, there has to be another procedure or service that was performed with a global period of either 0 to 10 days. So if you're in surgery, you probably are very familiar with a global period or global surgery. So payment for surgical procedures actually includes preoperative work, intraoperative work, and some postoperative work and services. And those services are those that are routinely performed by the surgeon or by members of the same group with the same specialty. Now, if you're curious about specific global period days and you don't know where to find that, it can be located on the Medicare Physician Fee Schedule lookup tool. And I have that link included here. You go on that tool, you'll just kind of follow the prompts. They also give information on how to use it. And then you would be able to look up a procedure code to see what the global period days are for that specific procedure that you're looking for. Now, it's important that you do not use Modifier 25 when billing for services performed during a postoperative period if it's related to the previous surgery. And so that would be something that has like a 90-day global period. So again, Modifier 25 is used only when it's a 0 to 10-day global period, and as well as meeting that other criteria of the E&M being separate and identifiable and significant, right? So if a patient has had a procedure where there is a 90-day global period and they come in for, let's say, a different reason than something related to that surgery, then that's a different modifier. That would be a modifier 24. We're going to limit this presentation though to 25. So just keep that in mind. Modifier 24 is different. That's for something when an E&M when it's performed within the 90-day global period. But modifier 25 is not to be used when a procedure that's performed has a 90-day global period. Also, sometimes in the hospital in particular, the providers, specialty provider may come in and consult on a patient and make a decision for surgery. So maybe somebody had a slip and fall and they broke a bone, and an orthopedic provider goes in to consult on the patient, and then they make the decision, yes, you actually need surgery for this break. That evaluation and management service that was performed then would require a modifier 57. So that is not a 25 situation. So again, because that procedure that they would be deciding to perform would have a 90-day global period, which would mean you cannot use modifier 25. Also, it's important to note that that new visit complexity code, G2211, if you are aware of that code and you're using it, you cannot append that. You cannot use that code when modifier 25 is attached to your E&M. They will deny the G2211 if there's a modifier 25 on your evaluation and management code. So that's just a tip. Just remember that. Now, if you're curious about the G2211, we do have another webinar available on that topic specifically that goes into detail on when to use that and give some documentation examples of that as well. And also do not append modifier 25 to CPT code 99211. That's a nurse visit. That should not be appended. That's not appropriate. So that also will not fly. And that would be also a red flag for your payers. So let's talk about some examples. So I actually pulled some really great examples from Medicare, and they have some great tips. So the first site that I used was, again, First Coast Service Options, which is the Medicare administrative contractor for Florida. So they've given 5 examples. The first one is, let's see, why is this patient being seen? So other signs or symptoms, are there signs and symptoms or conditions a physician or other qualified healthcare professional must address before deciding to perform a procedure or service? If yes, based on documentation, an E&M service might be medically necessary with modifier 25. So here's an example that they gave. An established patient was scheduled for a follow-up E&M after a change in his blood pressure medications. The physician met the documentation requirements for a 99213. The patient then complained he was washing dishes, dropped a glass, and now his thigh muscle felt like a piece of glass went through his skin. So based on the signs and symptoms documented, the physician performed a 20520 removal of a foreign body in a muscle or tendon sheath simple, which has a 10-day global period. So the proper billing would be the 99213 with a 25 modifier and 20520. So this example that they gave is pretty clear because the patient was seen for a follow-up on their blood pressure medications, and a change was made to their blood pressure meds, and then they also had an injury. So these are clearly two separate conditions that were addressed, one of which required a procedure. So this is a very clear, appropriate use of modifier 25. So this is a very clear example of a thumbs up for a modifier 25. And again, if you plug your CPT code into that physician Medicare physician fee schedule, you'll be able to see global days on there as well. So the second example they give is related to significant or beyond normal component of work. So let's just jump to this example here. So an established patient sustained a severe laceration to the scalp. Before suturing the laceration, the physician performed and documented a comprehensive history and exam to determine if the patient sustained neurological damage. The physician performed a 3-centimeter intermediate repair, so CPT 12032, to the scalp. Based on the signs, symptoms, and conditions documented, the physician went beyond the normal preoperative work. The proper billing would be procedure code 9921, so whatever that is, whether it's 1314 with a 25 modifier, and then also the CPT code for the repair to the scalp. So important point to make here. This is where the new rules for evaluation and management become very interesting, because only a medically necessary or appropriate history and examination is required for your E&M level, for appropriate E&M leveling now. So in this example, because the patient sustained a severe laceration to their scalp, it was appropriate and obviously medically necessary for the provider to obtain a comprehensive history and exam. Because if the patient sustained any neurological damage or there was a potential for that, they may have needed to order something like a CAT scan to, check the patient out further to make sure that they were okay, there wasn't any kind of concussion or whatnot. So that is going beyond just a repair to the scalp. So they went beyond just simply needing to repair that laceration. They needed to do a more comprehensive history and exam based on that injury. So this is where, again, that documentation is super important, because if we're not seeing that more detailed information within the history and exam based on the injury, then we may not have that support for that modifier 25. Even if the provider performs it, we don't know that, right, unless it's documented. So for any providers listening to this, again, it's just very important for you to, in this example, to expand upon the concerns and what's going on and the full exam that's done and what your findings are. So that it really helps to support that modifier 25 in that situation. If not, anybody that's reviewing it may have a difficult time determining whether that 25 is appropriate or not. And that could lead you down to a negative finding in an audit. So again, just making sure that documentation really supports that 25. So here's another example from First Coast. So this one, I mentioned this a little bit earlier. So a procedure scheduled before an encounter. So was the procedure or service scheduled before the patient encounter? If yes, it's not medically necessary to bill for an E&M with modifier 25. So example, patient was scheduled to have a lesion removed from her right leg. The physician examined the lesion, infiltrated the lesion with 1% lidocaine. The lesion was removed and a simple closure was performed. So the sole purpose of the visit was for lesion removal. Therefore, billing an E&M with modifier 25 would not be appropriate. And so this actually happens quite a bit in dermatology, where patients are scheduled for lesion removals, and unless the provider or billing and coding personnel are super familiar and understand the use of modifier 25, this could be an area of overbilling. And this has come up on OIG audits a lot. And again, this happens a lot in dermatology. It also happens in orthopedics. I'd say those are the two biggest areas in healthcare where modifier 25 usage is questioned and where a lot of the audits happen. So just remember, if it's a pre-scheduled procedure and that's what they're coming in for, it's normally not appropriate to append modifier 25 unless something else goes on during that appointment. And again, it has to be something significant and separately identifiable. Otherwise, the work that's put in to performing that procedure is considered a part of that payment for the procedure. So many times providers say, yeah, but I've got to examine the patient to make sure that they're able to undergo the procedure that day. You have to make sure they're feeling well and that nothing's out of the ordinary. If I asked them to hold a blood thinner or whatever, I have to check with them. I have to evaluate them and make sure they're okay to undergo the procedure. Well, that's actually included in payment for the procedure itself. So that's part of that pre-procedural work. And so they do not allow for billing an E&M separately for that service. It's part of the pre-service work. So that would not be appropriate. So another example they give is more than one diagnosis is being addressed. And so we sort of saw an example of this, before. The first example, I believe it was. So is there one or more diagnoses present being addressed or affecting the treatment and outcome? If yes, bill the procedure code and the E&M with modifier 25. Medical necessity must substantiate the use of modifier. So again, we show all that through the documentation. So example, an established patient visited her internist for a follow-up of hypertension and diabetes. The patient also complained of shoulder pain. The physician performed a problem-focused history and exam, evaluated the patient's hypertension, and determined the blood pressure was higher than usual and adjusted the medication regimen. The patient's blood glucose was normal. The physician also evaluated the shoulder and determined the patient would benefit from an injection there. So the physician evaluated the shoulder before performing the service, but also evaluated the hypertension and diabetes. So of course, here again, this is kind of a softball, right? We have technically 3 problems here that are being addressed during the same visit. So the modifier 25 would be appropriate on the E&M, and then you would also be able to bill for that procedure as well. So that injection. So let's take a look at another example, E&M on the same day as a wellness visit. So this one is a question that's asked a whole lot, and we probably could do a whole webinar just on this with examples. So who knows, maybe that will be coming up here in the future. But so an E&M on the same day as a wellness visit. Is payment allowed? The answer is yes, payment is allowed for a medically necessary E&M service at the same visit as an annual wellness visit or the initial physical exam. When the E&M service is clinically appropriate and medically necessary to treat the patient's illness or injury, or to improve the functioning of a malformed body member. So components of a medically necessary E&M service, so for example, a portion of the history of physical exam, may have been part of an annual wellness visit or the initial preventative physical exam and should not be included when determining the appropriate level of the E&M service. Now that has actually become a lot easier because the E&M services now are we level them based on the medical decision making, right? So that sort of has alleviated quite a bit of that. But if all requirements are met, modifier 25 can be appended to the E&M code. So the example they give is an established patient was scheduled for their annual wellness visit today, but yesterday they actually fell and hurt their knee. So the physician performed and documented a medically necessary E&M service, so for their knee, and they did that at the same time as the annual wellness visit. So the annual wellness visit, obviously, you're going to go over their chronic conditions, what medications they're taking. You're going to make sure that the anything that they need to have done for preventative care is lined up, anything that they may be due for. You're going to go over all of that. And again, it does include review of their chronic conditions. But in this case, this patient hurt their knee, so they now have an injury from the day prior. So there was a separate evaluation and management service performed for evaluating their knee. So when you look at leveling that evaluation and management service, you would have to focus in on the medical decision-making related to their knee evaluation. So what was the final diagnosis for that? What was the data, if any, that was reviewed? So was there an X-ray that needed to be ordered, or was there something, maybe they already had an X-ray done yesterday? Did you review that? Did you do an independent interpretation of that? And then what is your recommendation? So what's the risk of management for that patient? If you prescribe medication, obviously that's a certain level of risk, that moderate level, versus again, maybe you're just ordering some basic testing for them to have done. Maybe you are ordering that X-ray. So you'd have to level that E&M based on what's there for the knee. But just a review of their chronic conditions, that's included in the wellness visit. Now, if there was something that was way out of line, suppose you were reviewing their health for their wellness and they have hypertension and their blood pressure was way out of control, turns out you had to make some medication adjustments for their hypertension, that again, as long as you document it appropriately, maybe where you could also add that E&M with the modifier 25, but your documentation really has to show that and support that it was significant and separately identifiable. So this example is actually from Palmetto GBA, which is another Medicare administrative contractor. So I just thought it would be good to get a couple of examples from another payer, for example, here. So this one, the beneficiary was seen in January, and it looks like there's an injection code here for a knee injection that has 0 global days. So an E&M service is submitted with a 99214. Patient was scheduled to receive an injection in the left knee, but due to failure to control pain and inflammation in the knee with prior medical treatments, so the patients had oral meds and prior joint injections, further evaluation, so there was an additional assessment and intervention, was performed by the physician, and a total knee replacement of the left knee is planned. So the outcome of this was they submitted the CPT code for the E&M visit with modifier 25, and then also that injection. And what supports the E&M here is the fact that they had to do that additional assessment and planned intervention for the planned left knee replacement. So again, this is that example where, okay, yeah, they plan to come in for an injection, but it turns out the patient's actually worsening to the point that now we're talking about a major surgery, right? So documenting that major surgery, the decision for them to undergo that is, has to be documented and everything, because you have to show that that was a significant piece that was discussed and that it's separately identifiable from just giving that injection. So that again is a great example of where you can use it for the same diagnosis. But again, we shouldn't see this every time. We shouldn't be seeing them come back in again and then, oh yeah, we're planning on doing this, left knee replacement, but they just haven't scheduled it yet, or it's going to be scheduled. So just be careful with that too, that frequency of it. Make sure that there's no copy and paste issues in there to protect yourself from any possible modifier 25 overuse. So we have another example here from Palmetto. So on this one, February 15th, an E&M service is submitted with 99213. Patient was evaluated for treatment of neck pain and elevated blood pressure. So a trigger point injection was administered for the neck pain, and then new meds were prescribed to control the patient's elevated blood pressure. Outcome, so that E&M with modifier 25 and that CPT code for the trigger point injections would be appropriate. And again, this one is more clear because there are two separate diagnoses that were being treated. However, I do see sometimes where providers, this may have actually occurred, but then the interesting thing is they don't necessarily call out the hypertension in the assessment and document a full plan. Like sometimes they'll just put like the change of the med under the plan. So again, be sure that you're really documenting in your assessment and plan, like really the full picture of what happened, because otherwise you may not really be showing a true picture of what's going on, where in your mind as the provider, you're like, oh yeah, this is definitely like a significant and separately identifiable situation here, because I had to talk to them about their blood pressure and I had to actually change their medication because of it being out of control here. But if you don't document it fully in the assessment and plan, we don't know that. So we really need to make sure it's there to support that 25 being appended to that E&M. So here is an example that Palmetto calls out that's inappropriate or incorrect use of modifier 25. So on January 24th, an E&M is submitted with 99213 and modifier 25. So during the same patient encounter, the physician also debrides the skin and subcutaneous tissues. So that CPT has a 0-day global period. 99213 was submitted to reflect the physician's time, examination, and decision-making related to determining the need for skin debridement. The physician's time was not significant and separately identifiable from the usual work associated with the surgery, and no other conditions were addressed during the encounter. So the outcome, do not submit the E&M service. The E&M service is not separately reimbursable from the surgical procedure. Submit only the surgical procedure. So this is where I was talking about how pre-procedural work is included in the actual procedure itself. So if that patient comes in and you decide to do a skin debridement, and that's the only thing that they're there for, unless there's something really significant and separately identifiable, that's all you should be reporting is the procedure. Again, any work that you do during that visit and determining that, okay, they're good to go, it's appropriate to do this, they need this done, is included in that procedure code. So let's talk about some recommendations. So remember the tips from slide 8. So remember that new patient code situation that they normally do not require modifier 25. The exception was if that E&M is performed on the same day as chemotherapy or non-chemotherapy infusions or injections. But just consider the payer and have your team work with you to get to know the guidelines for your Medicare administrative contractor and your other payers that you may have. Obviously, not all providers only have Medicare patients, right? So your commercial payers too, just get to know what their policies are. And then also consider how claims process. So why I bring that up is sometimes we get the wrong idea, right? So like when you perform a service and then you bill it out, all the insurance company gets at first is an electronic claim. So on their end, on the receiving end, their systems electronically receive that data. Their systems are actually set up to do a scrubbing on their end that can sometimes automatically deny something without an actual person looking at it. So it's important to have a good team in place on your side that can take a look at those rejections or denials that come back in and dig into those and find out why that payer is rejecting or denying those claims, whether it's automatic or is somebody actually looking at this. So sometimes you may have to submit documentation, appeal, or again, look at their policies in regard to modifier 25. And that billing guidelines do differ from carriers and MACs and from state to state. And so sometimes it's important to consider taking like a small number of claims and test them prior to making major changes across the board. So certainly don't take this information and then just say, okay, so across the board, we're just going to start doing this now. Work with your team and discuss like, what is our current process? What do we have in place? Are we reporting modifier 25 too much? Maybe there's some services where we actually don't need it to be appended. Let's kind of investigate that. And, you can send in some test claims to check that payer's process. You'd be amazed too how many times you could call a payer, talk to someone on the line, that person gives you some information, but then you realize the reality of it is different. So you may submit the claim exactly how they say, but then there's some kind of automatic denial or rejection that comes back. So it does take a little bit of time. So test small number of claims prior to making any major changes across the board. And then once you have your system in place and you've dotted your I's and crossed your T's, you should be good to go. Just remember, work as a team. It's really, truly a full team effort. So having you as a provider or you as a coder, like in line or biller in line with the whole team, and that communication is super important to have a seamless process and get these claims processed appropriately. So I hope that you've enjoyed this presentation. We are just going to take a bow here. And hopefully this has helped you out. Feel free to comment to us. Don't forget that we have a YouTube channel where you can join us for Tea Talk Tuesdays, where we give free advice, we answer questions. So it's actually an interactive live stream. So you're able to join. It's open to the community. This slide here has some additional references and resources related to Modifier 25. So all the information that we've used within these slides has come from these sites here. And so feel free to reach out to us with any of your needs. We do offer auditing, consulting, and full revenue cycle management services. Just remember, you heard it straight from the horse's mouth, and contact us with any questions. Thank you so much, and have a great rest of your day.